Okay, the next section is going to be about certain concepts relating to what you would need to consider when prescribing or choosing a drug. The first concept is called the spectrum of action. There are two types of drugs with regard to spectrum of action. One's called a narrow spectrum drug, and the other is called a broad spectrum drug. So these would be the categories that would be defined as how effective or how many organisms does the drug kill, or does the drug is the drug effective against. A narrow spectrum drug is only effective against a small group of organisms. So on the chart down here below, you'll see polymyxin is limited only to a subgroup of the gram-negative bacteria. You see that cyclovir is only useful against viruses. So these are narrow spectrum drugs. They're only effective against a particular group, and even not even all within that particular group, but a small group of organisms that can be treated with that drug. On the other side of this, you have what we call the broad spectrum. And a broad spectrum drug on this example would be like the sulfonamides. They are useful against some of the gram-negative bacteria and the gram-positives, chlamydias and rickettsias, and even into the eukaryotes, some protozoans. And so that would represent a fairly broad spectrum drug. And then you have some that are sort of in the middle. But on the test, I'll pick something that's either very narrow spectrum or very broad spectrum, maybe give you a chart like this and ask you about a particular one, maybe polymyxin, for example, and then you would need to recognize that because it only affects a small group, one subgroup of the prokaryotes, that would cause it to be referred to as narrow spectrum. Something that spans many groups, is effective against many groups, would be called broad spectrum. You might think that broad spectrum drugs are always the better choice, but in fact, what happens when a broad spectrum drug is used is it not only kills the organism that's causing the problem, the disease, but it might also kill what we call the normal flora or the normal microbiome. And what that does is then sometimes opens up opportunities for what we call secondary or super infections to then develop. So if somebody takes a broad spectrum antibiotic, it's not unusual for that antibiotic to work against the initial infection, but typically, a week or two later, that individual has a second infection with something else. So yeast infection as a secondary infection is actually a pretty common occurrence when a patient is treated with a broad spectrum antibiotic. So that's kind of the downside of using a broad spectrum antibiotic. If you have a very good identification of the organism causing the disease, then you would choose, if you can, a narrow spectrum drug. If you don't have a very specific identification of the pathogen that's causing the disease, that's typically when you have to use something more broad spectrum. So we do use some tests to figure out how susceptible a pathogen is to a drug. One of the tests we do is something we did in lab. It's called the Kirby-Bauer test. And in the Kirby-Bauer test, in this example in the picture, you spread a bacterial species all over the plate, and then you drop these antibiotic discs onto that spread plate, and then you incubate overnight, and the drug will diffuse from the disc outward in all directions, and there will be this zone of clearing. We call it the zone of inhibition, where the concentration of that drug is high enough to prevent the growth of that bacterium any closer to that disc. So where that boundary line is represents the point at which the drug becomes at least inhibitory and probably to some extent bactericidal to growth of the cell. Now, the difference between the concentration that is inhibitory towards the bacterium and the concentration that is lethal to the bacterium is typically determined using a different kind of test. But Kirby-Bauer can give you, remember that we measure the zone of inhibition with a ruler, and then we can use a chart to determine whether or not the organism is resistant or sensitive to that particular antibiotic. So on this slide, I'm going to show you this minimum inhibitory test. Let's say this plate is it's a plastic plate that has these teeny tiny little plastic test tubes fused to it, and they're open at the top. You have these teeny tiny test tubes all in a row here. And what happens is you put the culture into, or you inoculate each of these with a tiny bit of the bacteria, and then you add an increasing amount of the drug. So let's say you have a tiny bit of the drug on this first tube here, and then as you move across, this last one has a lot of drug. And you would know what the concentration is in each of these wells. And then you incubate it. Now, these first couple, probably over here, you definitely have some growth in the wells. So you see that the wells are turbid, that means cloudy. And there's a point at which, let's say, you have clear wells. So what that would mean is whatever concentration this is right here, that represents the point at which growth of the bacteria is inhibited by that concentration of drug. That's called the minimum inhibitory concentration. So as long as you have this amount of concentration of the drug or greater, then the organism cannot grow. However, what you won't know is if the organism is dead inside the well. And so typically you want to go to the next test. No, not that one. The next test, which is called the minimal bactericidal concentration test. So you remember these tubes that were clear in the minimum inhibitory concentration test? You would take samples out of them. And so maybe this one was clear, but when we take a sample and put it on a plate, it still grows colonies. So that means the cells in this tube had enough drug that their growth was inhibited, but it wasn't enough to kill. And you keep testing the tubes from the MIC test, and you'll get to a point where you have the first tube that doesn't give you any colonies on the plate. That level of drug is the amount needed to kill, and we call that the minimum bactericidal concentration. So you have this minimum inhibitory concentration where it's a level of a concentration of drug that stops the growth, but there's also at a slightly higher level of drug, you have the minimum bactericidal concentration. So somewhere in between there, in that range, is where you want to prescribe the drug to the patient. You want to at least stop the growth of the bacteria and, maybe even kill the bacteria. The problem sometimes is that the more of the drug you give the patient, sometimes there's more side effects. So it has to be adjusted to a level that at least stops the infection, if not kills the infection, and yet doesn't cause side effects, hopefully, for the patient. Now, how do we put drugs into the body? We have different administration methods, routes of administration. Topical means rubbing it on your outer surface, on your skin. It could be putting something on your gums if you have a sore spot on your gums, but something where you just apply it directly. And that drug does not go into the bloodstream, or at least not at a real measurable level. Now, an oral route of administration means you swallow a pill or you swallow a liquid suspension. Intramuscular administration means you get an injection into the muscle, and intravenous administration delivers the drug into the blood, so into a vein. Over here, you can see on this, and this is not meant to be any particular, I don't know why they put actual hours, but for example, let's say you had a drug and you gave it in an oral method. What you're seeing here on this graph is on the y-axis, it's the level of the drug or the concentration of the drug in the blood. So the blood concentration of the drug. When you take a drug orally, it takes a while. It does get into the blood supply because there's a lot of vasculature in the digestive tract, so it will be absorbed into the blood. It takes a while and it doesn't reach a super high level. If you get an injection either into the muscle or into a vein, a one-time injection, you'll get a much quicker and a much higher level. But then the blood goes through the liver and the liver will detoxify. So you'll always have this this curve that goes down, and that's where the liver removes the drug from the blood. Removes drug. So your liver is constantly removing drugs. It doesn't matter if it's a legal or illegal drug. Your liver doesn't know. It just removes any drugs from your blood. So if you take a one-time oral dose or a one-time injection, you will get, eventually it will be removed by the liver. The only way to keep the level high constantly is to have a continuous intravenous delivery, which would be like a drip. So you would have to have a bag that's hooked up to your arm. There's a port in your arm, and usually that's what they do. And then you would have to carry that bag around all the time. Or if you're in the hospital, it's hanging next to the hospital bed. So that would give you a much higher level and keep it continuous. Because even though your liver is constantly removing it, the drip then introduces more drug constantly. So that would cause you to have the blood levels be maintained. And the time scale here isn't something you need to memorize. It depends on the drug, how quickly it's removed by the liver. But these are considerations that the doctor has to consider, because it's much easier if you can put a drug out on the external surface of the body. That's the easiest one. You don't need any special training to do that. To swallow a pill or to swallow a suspension, sometimes there's instructions that come with that, just in terms of, do you need to eat a meal when you take the drug or not eat a meal? Or, sometimes that's a little trickier to get done correctly, but you don't need a special training really to do that. But if you're going to get a shot of some type, then you're going to want somebody who's trained to do that. For patients who have to give themselves shots on a regular basis, obviously they learn how to do it. But for the general population, we're going to let a professional do that. And then if you need an intravenous drip, of course, that's going to require a lot more equipment and a lot more training. So as you go down this list, these routes of administration are more difficult and require more expertise to achieve, but the more difficult routes also give you the higher levels of drug in the blood. So it's completely dependent on what's needed. That's how the doctor makes that decision.